Good evening, friends. Welcome back to my channel, Pediatric Classes. Today, we are going to discuss a very important topic, that is the autism spectrum disorders. So, this will be based on the guidelines from the IAP, that is our IAP STG guidelines, that is Standard Treatment Practice Guidelines. So, with this intro, let me start sharing my screen. And if you have not subscribed to my channel or viewing this channel for the first time, please do subscribe to the channel. Okay, so this will be the discussion. At the onset, let me thank the lead authors, Samir Hassan Dalwai, Doctor, and Dr. Shabina Ahmad, Dr. C.P. Ravi Kumar sir, and our Central IAP President, Dr. Ramesh sir, and all the IAP senior members for bringing out such a wonderful guidelines. Thank you so much. And so what exactly is this autism spectrum disorders? So spectrum, actually this indicates that each individual will be affected in different ways. So it can range from mild to moderate cases. So what happens here is, whether it is mild or it is severe symptoms with overlapping comorbidity, everything will come under this heading of autism spectrum disorders. So by definition, it is a biologically based neurodevelopmental disorder with deficits in two domains. So one domain is a social communication or interactions, and another thing is about their restrictive or repetitive patterns of behavior. So these are the two things which are found to be problematic in an autism spectrum disorder. One is the interaction between the peer groups and other people, and another thing is about their restrictive or repetitive patterns of behavior. So what about the clinical features? These symptoms generally appear before 3 years of age, but sometimes it may be obvious over time when social demands exceed their limited capacities. So generally, if you probe into the history, we'll get the history much before 3 years of age. So what are the red flag signs for autism? So one thing is poor response name called by 1 year of age. So if all pediatricians make an effort, so when they come for their vaccination by 10 months, and just make sure that you call the baby's name and they actually look into your face. That is can be taken as a mind screening test also. So at least make sure that whether they are having an eye contact or whether are they responding to your call. So if there is a poor response to name call by 1 year, or if they don't say any meaningful words by 18 months of age, they do not play with the toys appropriately, or if the kids are having a fixed pattern of interest or activities, if there's decreased interaction with peers or friends, if the child has odd movement patterns or very repetitive behaviors, demonstrate echolalia. That means whatever we say, he repeats back. So that is actually he or she repeats back. So what is that? It's called echolalia, or the child is hyperactive, or the child has slow walking. So these are just the red flag signs. So it doesn't mean that the child has slow walking, the child has autism. Okay, this is one of few of the red flag signs for autism. So what are the conditions co-occurring with ASD? The ASD can co-occur with intellectual disability, with attention deficit hyperactivity disorders, sleep disorders, feeding and GI symptoms, seizures, obesity, anxiety, and wandering, and all those things. So now that gets us to our differential diagnosis. So one is hearing loss. See, that we are telling that there is a lack of social interaction. So what if the child is having hearing loss? The child will have non-verbally, the child has a normal social interactions, but verbal communication will be lacking. That means that when actually you can try see whether the child has an eye interaction and other things. Selective mutism is the child is completely mute only in the presence of strangers. There's another different type, is a global developmental delay or intellectual disability. Here what happens is the development is globally affected and social communication is affected on par with other domains. In ADHD, what happens? Social communication domain is not significantly affected. The hyperactivity is usually meaningful and intelligence is not affected. In ADHD children, they are generally their intelligence will be all right, but they will be just running around. They'll have sometimes inattention and other things. So when should we screen? The best time to screen a child is between 16 months to 30 months. They should be screened with MCHAT or MCET-RF combined with clinical evaluation. In the next video or in this, in a few after few videos, I'll be coming out with a detailed video on this MCHAT. Okay, it's a very good screening and easy screening test. This is based on a questionnaire. Okay, so what is how exactly we diagnose this? There is no single test. That is what we should understand. There is no single test available for or appropriate for all children. So we need a comprehensive evaluation by a team. There should be a developmental pediatrician. They also should take into account all the. We should actually take into account how exactly the child is responding to the calls. Excuse me. Hello. പറയൂ. ശരി. ശരി ശരി ആയിക്കോട്ടെ. ശരി 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 ശരി. ഓക്കെ ഓക്കെ ശരി ഓക്കെ. I'm sorry for the interruption. There's a hospital call. That's it. Okay. So how can actually we are now discussing about the diagnosis partner. So there should be a development pediatrician. There's a whole team actually involved with it. There's a psychologist. There's a person who can do the MCHAT evaluations and other things. So what actually is here, we require a proper history and physical examination. We need to use tools such as that actually depends on the observation also and what actually the parent tells us. So what are the measures relaying the parents report? We have so many screening tests. It is ABC, that is autism behavior checklist, Gilliam autism rating scale, diagnostic review, or so many things are there. And another thing is using the direct observation. What exactly we observe? That is about the CARS, that is childhood autism rating scale, and the ADOS, that is autism diagnostic observation schedule. Okay. And then the developmental IQ testing with separate estimates for verbal and non-verbal skills should be done. Assessment of adaptive skills to document the presence of associated intellectual disability should be done. Sensory motor and or occupational therapy evaluation, speech, language, and communication assessments. All these things actually are required for making a diagnosis. Just like that one or blanket diagnosis we cannot make in such a case. What about the investigations? We should do investigation for hearing, vision, all should be checked. CBC and thyroid function tests are also recommended. Routine metabolic testing, biomarkers, environment dogs are not actually recommended. Lead levels are indicated only when there is a definite history of exposure. So when exactly we recommend a neuroimaging. So in a case autism spectrum disorders, we recommend a neuroimaging when there is an abnormal neurologic examination, when there is seizures, or when the child has also associated headache. When do we recommend an EEG? EEG is indicated only when there is history of unusual spells or behaviors, frankly suggestive of seizures, or when history of significant regression in language skills, as in case of Landau-Kleffner syndrome, that is acquired epileptic aphasias. So we do not require all this EEG and neuroimaging all cases, but certain selected cases, yes, we need to do according to the indications. Genetic evaluation recommended only in the presence of dysmorphic features or in intellectual disability. No mutation has been actually associated or found specific for ASD. And it is better we test for Fragile X syndrome for all children with ASD, especially for boys and children with a suggestive family history of male members with intellectual disability. This associated intellectual disability is better we test this. And what about this chromosomal microarray? This is recommended if etiology is not known. It reveals a pathogenic copy number variant CNV in approximately 9%. So we generally in practical cases, we generally don't do all this. But if you can, attempt. In history and clinical examination, CMA, Fragile X, and all this do not do reveal etiology. It is recommended to advise whole X. If they do not reveal, you can do this WUS, which allows for the identification of single nucleotide variants. So this is another thing. So what about this genetic counsel? It's very, very important because the risk of autism spectrum disorders in the next pregnancy is around 10% greater with one child and about 34% with the 2 or more previous children with idiopathic autism spectrum disorders. So this has got a genetic thing. So we have to be very careful and we have to advise genetic counseling. This percentage will be very important for this NEET entrance aspirants. See 10% with one child and 34% higher risk with 2 or more children with ASDs. So how exactly can we manage? So at least we have a provisional diagnosis, but and also go look for associated comorbidities and rule out other differential diagnosis also. No, there is no single proven therapy. So actually, what is more important is the earlier you start therapy, the better the prognosis. So always, the thing is every moment which is the child is awake, every awoken moment actually is very, very important. We have to give stimulation to the child. We have to intervene. We can train the children. Intervention should target core features of autism. What are the core features? That is the deficit in social communication and interactions. And another thing is about the restrictive or repetitive patterns of behavior, activities under interest rather than symptoms such as delayed speech and hyperactivity. So the eye contact actually we should try to improve in the children. In one of these articles I was reading, they are telling they are advising small colorful glasses. They are telling the parents, the therapists can all wear that so that the children looks into your face. Slowly the interaction, eye contact should be made. Intervention should be evidence-based, structured, and appropriate to the developmental and functional needs of the child in association with the parents and family. They should have a larger component of home and community-based intervention rather than just clinic-based. What it means is just don't do it at in clinic. Every moment we at home, every time we should actually train the child. Management of comorbidities is really important. Yes, we need to treat if intellectual disabilities. We have to take into account those things also: ADHD, anxiety, depression, etc. So pharmacotherapy is useful only when there is a target symptom or comorbid conditions. Like for example, if there is an ADHD, yes, can consider methylphenidate and atomoxetine. If there is a risperidone, we can go for aggressive behavior. SSRIs, that is selective serotonin reuptake inhibitors such as fluoxetine or sertraline, can be tried for anxiety and repetitive behaviors. Melatonin may be used for sleep disorders, but then pharmacology management, seizures and GA disorders are same like any other child who are having autism spectrum or not having autism is same. Treatment programs should be monitored also to ensure appropriate response to therapy. It should be reviewed and modified as the child's abilities and needs change over time. The child's require motivation, parents require motivation. Actually, the thing is we have to take the parents also into confidence to explain to them. We have to try to do the best for the child. The role of pediatrician is early suspicion, counseling of the parents, appropriate referral, and most important, regular monitoring to note the improvements in the child from time to time. So just don't just say you use such weird statements or a blanket statement like the child can never be normal and such things. No, that will actually demoralize the parents also. They may refuse intervention also. They may go for some alternative complementary therapies and they may not get the response too. So please note, non-goal oriented, arbitrary, unending, repetitive, symptom-based intervention should be monitored for their effectivity. Okay, versus their potential harm to harm the child, as well as take up the golden early period that they always say earlier the better. So try to pick up the cases early. Try to use find out the get the red flag signs if any child is having it. Find it out, pick it up, give an early referral or intervene early, give early stimulations and other treatment modalities. With appropriate intervention, most children with mild to moderate autism spectrum disorders, especially in the absence of severe comorbidities, they can actually lead a normal or a meaningful social inclusion life with all those things. So please note here, it is the early suspicion and the early intervention actually which plays an important role in this, and also the presence or absence of the comorbidities. So always just don't say the child is autistic. We have to see whether any comorbidities are there also. So there are certain myths and facts regarding. Some people say there is some vaccines cause ASD. There is no clear evidence. And so about the dietary changes, no, gluten-free, casein-free diet and all are not recommended for children unless they are having some celiac disease or gluten sensitivity. Similarly, about the complementary and alternative therapies, they also are not found to be of much use. They are not actually not recommended. The guidelines do not recommend that. They are like antimicrobial agents, IVIG, vitamin A, B6, magnesium, all those things. They are found not to have much role in the treatment of autism spectrum disorders. This according to the IAP SDG guidelines. So to conclude, early intervention is a buzzword which is equally important to have the correct, appropriate, and dynamic intervention based on a whole documented and holistic program. Okay, so now with this, I hope you have got a bit of an idea about autism spectrum disorders. It's a very vast topic where the guidelines are really good. Please refer to the guidelines. It is really available in the net. Thank you so much and stay safe.